The next presentation will be a video as well from Dr. Steve Preece, but we are hoping that he'll be able to join us for the questions. So please do enter any questions that you have got into the chat, and we're hoping he'll be able to be here to answer them. This presentation is entitled The Development of a New Behavioural Intervention for Knee Osteoarthritis.
Good afternoon. My name is Dr. Steve Preece, and I'm the Research Centre Director for the Centre of Health Sciences Research at the University of Salford. I'm going to talk today about a new intervention I've developed for knee osteoarthritis, which I'm going to call tension release therapy. I'm sorry I can't make it today, but I will be around afterwards to answer any questions you might have. Our new treatment has been developed for knee osteoarthritis, and this is a condition which is characterized by cartilage loss at the knee joint, pain, loss of function, and stiffness. Now, lots of research has shown minimal association between the cartilage loss at the knee joint and pain. And therefore, it's not a simple consequence of degeneration which is causing people's pain. There's plenty of other factors at play. Now, the current treatment for this is physiotherapy, which is focused on muscle strengthening. And this typically leads to about a 25% improvement in pain. But unfortunately, about 40% of people don't experience any benefit at all from this approach. People with knee osteoarthritis have prolonged and increased activity of the knee muscles during walking and other functional activities. And you can see this illustrated on the picture on the left, which shows a typical osteoarthritis muscle pattern. That's the hamstrings and quadriceps activated at the same time. Whereas in a healthy person, those muscles turn off after the early stance phase of walking. People with osteoarthritis also demonstrate sensitization to pain, and that's modulated by emotional factors. And importantly, the current physiotherapy management, which focuses on muscle strengthening, doesn't really aim to change these functional muscle patterns or incorporate aspects of psychological pain management. Our new intervention is based around a three-component framework, which incorporates postural mechanisms, central sensitization to pain, and maladaptive motor responses. And I'm going to talk about each one individually now. So our postural mechanisms is based around some biomechanical research which we've done recently at the university, which links posture with elevated knee muscle activation, as you can see in the green box at the bottom there. Recent research that we've just published shows that in people who sit for prolonged periods and who are inactive, there's an increase in the passive stiffness of the hip flexor muscles. So you can see that in the diagram in the middle of the slide. We've also seen similar stiffness in people with knee osteoarthritis when compared to healthy control subjects. The hip flexors flex the hip or anteriorly rotate the pelvis on a fixed femur. Now, what the animation is showing you there on the right-hand side of the screen is the movement of the pelvis as we return from a forward flexed to an upright standing position. Now, this rope shows the effect of a short hip flexor. And what you can see is that the pelvis can't rotate properly on the femur, and it creates this forward-leaning standing position. And the same effect is observed in walking. So the graph on the left shows a correlation that we've observed between the length of the hip flexor muscles, measured using that clinical test I showed you before, and the degree of trunk lean during walking. To understand the effect of increasing trunk lean, we asked healthy people to walk upright and then with a very slight 5-degree forward lean. And what we saw was that the muscle patterns in the hamstring changed from those which you see in the black line towards those you see in the green line. And what's really interesting is that this green line is very similar to the knee osteoarthritis pattern. So it seems that that change in upper body position is leading to a specific change in the muscle activation during walking. So that's the final link then in our postural mechanism. It starts with prolonged sitting, physical inactivity. We then get passive stiffness of hip flexor muscles. We then get this compensation in postural alignment, and that leads to elevated knee muscle activation. I'm going to talk now about the next component, which is the idea of a maladaptive motor response to pain. Our concept of a maladaptive motor response is based on the idea that people could tense their muscles in response to knee pain. So this idea is shown in the diagram at the bottom, where people experience knee pain, they elevate their knee muscle activation, that increases joint loading, and so increasing nociceptor input, and thereby increasing knee pain. If that knee pain then triggers more knee muscle activation, people can be stuck in this vicious circle. The final part of our mechanism centers around the idea of central sensitization to pain. So there's now lots of evidence that pain circuits are altered in osteoarthritis. And what this means is that people with osteoarthritis are hypersensitive to generalized body pain and have decreased pain thresholds. And what's more interesting is emotional factors can actually modulate that sensitization. So research has shown that people who catastrophize more are often more sensitive to pain than those who don't. So this completes then the final part of our framework, focused around sensitization. If people experience knee pain, that experience is modulated by the way that their brain processes pain, which is in turn modulated by their response to pain and beliefs about pain. So that completes the framework. We've got these three interrelated mechanisms: postural, maladaptive motor responses, and central sensitization to pain. And I'll explain now how our intervention specifically addresses each. There are 5 different components of the tension release therapy intervention. The first is making sense of pain. Then we have general relaxation, postural deconstruction, responding differently to pain, and functional muscle retraining. And I'll talk through each now. Before I do that, I just want to clarify some underlying principles. The first is that we've incorporated a big digital focus within our intervention, using EMG biofeedback to facilitate muscle relearning, and using animated instructional videos to communicate concepts related to pain and biomechanics and posture. We also want to help people to self-manage in the long term. To do that, we're trying to provide an improved awareness of muscular and emotional responses to pain, and we want people to integrate this learning into their daily life to create a new normal. What we don't want is for people to have to continue to practice exercises in the long term. So the first component focuses on making sense of pain. And the aim is to teach patients to understand the cause of their pain and how it might relate to their muscle tension patterns, joint loading, and also their brain's method of processing the pain signals. The second component relates to general relaxation, and we focus here on observable indicators of increased muscle tension and muscle tone. For example, you see on the right-hand side here, this animation shows the effect of increased activity in the abdominal muscles, which prevents a proper diaphragmatic breathing pattern. The third component is called postural deconstruction. And the idea here is to teach people to become aware of the muscle activity that they use to stand, or their postural muscle tone. This is achieved by teaching people body awareness of different muscle patterns, not just in their knees, but throughout their whole body. So it's best illustrated with an example. If we see what happens here when someone tries to stand up with a short hip flexor, they have to flex their knees in order to be able to stand upright. And this necessitates a degree of quadriceps activation. So by using a EMG biofeedback system, we can communicate this idea of using tension to stand up. The idea here is to enable upright standing with minimal knee muscle activation. The fourth component we call responding differently to pain. And the idea here is to teach people to become aware of how they may tense their muscles in anticipation of a movement which they've previously found to be painful. To do this, we use EMG biofeedback to explore how beliefs and thoughts about movement can trigger the sort of tension you see there on the right-hand side animation. And that's been triggered because someone anticipates pain before they step down. The final intervention component is called functional muscle retraining. And what we're doing here is using EMG biofeedback to compare a quadricep or hamstring activity with that of a healthy person. And then we're using motor imagery to facilitate smoother, more relaxed movement. So you can see in this animation on the right-hand side, we might encourage people to think about a rope pulling their knee forward so that knee flexion becomes smoother. We've only got preliminary clinical data on a few people from this intervention. The data I want you to look at is waves 3 and 4, who went through towards the end of our intervention development project. And what we see there is an average pain reduction of about 70%, which compares very favorably to the standard escape package, which is offered for muscle strengthening on the NHS. And that's only associated with about 25% improvement in pain. So one of the key targets of our intervention is muscle activity or muscle co-contraction. And I just want to leave you with these 3 illustrations here of how our intervention has been able to reduce quadriceps activity during stance phase walking. So you can see here that the grey line is a healthy database, the red line is the pre-intervention muscle pattern, and the green line is the post-intervention muscle pattern.
So as I said, we had a video there, but Steve has managed to join us for some questions. So we have a question from the Q&A from Chelsea, and that's whether you think there's any evidence of long-term changes following your interventions.
Well, we did follow people up at about 9 months, and in 9 of the 11 people who'd had the intervention, the clinical effects were maintained. So 2 people actually reverted back to the sort of levels of pain they had before the treatment. So actually we're thinking there's probably about 70–80% retention of these skills. That follow-up was done in the middle of the lockdown, so it might even be better in the longer term because people obviously have been finding it difficult to manage because of the whole sort of COVID situation. So that could have impacted on things. We've not followed people up in terms of their muscle patterns, so we would need to do more research to see if the muscle patterns are maintained over the longer term.
I have a question as well, and it's similar to something that Chelsea was talking to us about earlier, and that's fear of movement. And I was just wondering how you teach people not to be scared of movement. How do you go about designing an intervention like that?
The key thing is to show them how their thoughts relate to something which is physiological. So you begin by trying to explore what people are scared of. So you might pick a particular movement. So like say stepping down off a step. And what people will often sort of demonstrate is this tendency to sort of tense their muscles in anticipation of that movement. And when they can see this link between their thought process, their belief, and something which is happening physiologically, that can be quite powerful for people, and actually powerful, sorry. And when you teach them that they don't need to do that tension and they can just step down in a more relaxed way, you often get an immediate impact that actually it doesn't hurt as much. And so that creates then a very positive or a positive biofeedback, a positive feedback loop in which that people start to realize that that sort of fear of movement is causing a contraction of muscles, which is actually exacerbating pain. And it's that experience, that experiential learning that I think helps people to move on from that fear of movement.
Okay, and relating to those kind of sessions, we've actually just had a question. We'll squeeze one more in, and it's Joe Reeves asking, how many sessions of that sort of feedback do you think are necessary?
We gave people 6 one-hour sessions, and it's a lot to get through, but that's what we've been told is the maximum feasible on the NHS. I think if you were to do it in a private physiotherapy setting, you'd probably want a bit more, but we think we can get good results in 6 sessions, as long as people have something concrete to go away and practice between the sessions, and you give them a reasonable amount of time, normally 2 weeks between the clinical contact sessions, to practice things.
Okay, perfect. Well, thanks, Steve. Thanks for the video and thanks for joining us for the questions. And we'll draw a line under the session there. So thank you to all our speakers.